Okay, class, this is Exam 4 Study Guide, just to kind of guide you in the right direction. Number 1, symptoms of a dying patient that should be treated and should not be treated. The main rule of thumb on that is you pick symptoms to treat that really are typically causing the patient distress. And that doesn't mean what's causing the family distress. So you just think about the things that might cause the patient to be in stress, things like agitation or pain or vomiting or something that's significantly affecting them, and you see that impact. There is no typical length that is agreed upon in terms of a grief response after someone dies. So just normalizing that for people and making them understand that your experience of grief may be very different from another person's is very important. Advance directives can be initiated only by the patient because it's their advance directive or their directive to their doctors in advance of them becoming terminally ill or critically ill. So when you hear the term advance directive, don't think that means that family members can do an advance directive. There is a method or a way in which family members can get get orders done for a do not resuscitate with the physician, discussing with family and using a most form, and one of those is in your resources. So if you want to look and see what some of those forms look like, I've given you copies of those. But when it speaks about advance directive, that has to be done by a competent adult. And once they become incompetent, an advance directive specifically cannot be done. It has to be done in a different mechanism, as I mentioned. Purpose and focus of hospice care, you'll hear more about that in your lecture, but the main thing is knowing that it is to really provide quality of life, care that supports quality of life for someone who is terminally ill. And that can be very broad depending on the patient's condition. You'll see some different policies about family support during and following a death in the hospital. Some hospitals have specific procedures. How long can the family stay with the patient? But really the biggest thing is at some point you're providing both care for the patient physically, sometimes emotionally, and very often psychosocial support for family during that process almost becomes paramount more than what you're doing for the patient. And then following the death, that continues on, and we'll hear more about when we talk with Carolina Donor Services next week, what other requirements they have and things that have to be done. I'll let you look up signs and symptoms of what a patient would be doing who is near death. That's very clear in your text. The issue in terms of when should hydration and nutrition for someone terminally ill be provided or stop being provided. The main thing to do in this situation is to kind of educate the patient, as long as they're able, and family, that at some point hydration and nutrition are not going to be the key thing. We tend to think that people dying are going to have hunger pains and things like that, because we do that when maybe some people have that when they're not terminally ill. But actually there's not a lot of pain of any sort associated with limiting or decreasing or stopping hydration and nutrition. And so educating people about that is very important so that they can make the right decisions for themselves. And at some point, as you know, it can become risky. If somebody's not very alert, we don't want to lead to their death being hastened because of aspiration as well. Your book's pretty clear on primary prevention strategies for osteoarthritis. We talked about in lecture about how to prevent hip dislocations using an abduction pillow. At home, there are other key things you want to teach the patient. I'll let you look those up. What do you teach them in terms of their mobility, ways they can turn, position, move, activities they can and can't do? And then how could you tell? If somebody had dislocated a hip, what would be the symptoms, or what would the patient's body look like? Other than pain, perhaps, what other things would you notice about the hip, the leg? What might be visibly able to be told or investigated to determine that? Joint commission does require, when patients are transferred from one care facility to the next, or one level of care to the next, that a complete handoff report is done. We know that within the hospital, from setting to setting, that's true, and that is also true outside of that. Obviously, other things to prepare the patient for a transfer include really, getting permission, getting consents signed for payment of the transportation itself, if they're going via EMS. But there's a lot of things in terms of making sure that what that report includes really is everything about the patient, meds, treatments, everything you typically would report from nurse to nurse, from shift to shift. You would report and give more of a progress update on how they're doing rehabilitation wise. I'm going to let you guys look up what phrenic nerve impingement is. It is something that can happen with rheumatoid arthritis patients following surgery. And, what is significant about that, what the symptoms would be, and, why it would be important to notify the physician if those symptoms occur. Goals related to body image, I think we talked about that in class. Just making sure that you can identify, appropriate ways to kind of talk with the patient about this, or what would you really want as a goal, not an intervention, but a goal that would really give you an idea that the patient is doing okay with their body image. What medications are given for when patients are having flare-ups for rheumatoid arthritis, as well as non-drug. I think we talked a lot about that, different kinds of therapies that are non-pharmacological, including like use of ice and heat for joints. When you have red swollen joints, you're much more frequently going to apply ice for relief, and particularly for RA, that's the common thing. I'm going to let you guys investigate what lupus nephritis is and what that means in terms of what would you be concerned with in somebody with lupus developing that symptom. Just knowing that lupus has episodes that are very unpredictable, and what kinds of strategies would you do to help the patient and the family cope with that. Infection prevention for joint replacement. We talked in class about how significant it is related to these being high-risk procedures for infection. So all the things that you typically have done for preventing cross-contamination and infection in the hospital settings for other type of surgeries are going to even be heightened with this. Know why patients with lupus have photosensitivity and what types of education is required for them to kind of manage that at home. Actions for anemia preoperative. As older patients that are getting some of these surgeries, they are going to potentially need time to kind of build up their hemoglobin levels before surgery. Of course, they could have transfusions, but generally, since this is an elective surgery and they've got time, sometimes they will get erythropoietin injections to kind of build them up and help that prior to and then recheck it again right before surgery and see if they're at a good level, along with the transfusion issues that you would need to do. Be prepared for if somebody comes in day of, and that's the day you determine someone's low, then you want to make sure that you have consents for transfusion, perhaps even during the case, at the same time you're getting the consents for the surgery. Let's see. We've already talked about how rheumatoid arthritis really interferes with body image, but it can also interfere with your lifestyle and activities, and how to support patients to have a good lifestyle. Sometimes you've really got to dig into what it is that is their norm that they would like to do, and see if there's a way you can strategize to make that better for them. Pain management for osteoarthritis. Obviously after surgery, or like in this case a knee replacement, someone is going to be on narcotic pain medications. We talked about the use of Depadur, and how to watch for symptom problems from that. But we want to kind of keep narcotic use just enough to control the pain, and then the patient may be bridged over to some of their own medications that they were on, because they may have gotten surgery on this knee, but they may have other pain in other areas. So when in doubt, we're trying to determine what's the best pain management strategy. Do we use multimodal effects, or do we use other things? Usually the physician needs to be consulted to make that determination. There are some in your book. Look and see what you're supposed to teach about stress incontinence to try to help that for patients. Some of these other things down through here I just mentioned in the video. What are you going to do when somebody has a high potassium in the hospital setting? What are you going to treat? What are you going to safeguard against? We already talked about hemodialysis catheters and what you can and can't do. Know your signs of metabolic acidosis. What kinds of actions would you take if patients are not coping well with their treatment or not wanting to get their treatments? How do you work with that? The primary goal from your care map related to CKD or end-stage kidney disease. Know the drugs that would specifically be given or typically be given for a hypertensive patient in an effort to avoid them developing chronic kidney disease. You're going to have to dig in, guys, and know your normal levels for albumin, phosphorus, sodium, and potassium. I didn't talk about albumin today, but patients, of course, are going to be on a low protein diet, and that is going to drive them to have a low albumin at times. And so that is another key thing that's got to really be monitored amongst these patients, and the therapy for that is how is their albumin level being held up. We don't see these low protein diets often ordered on a lot of general floors, but know what is a low protein diet in terms of grams, or how would that be ordered. Know the diet choices that would be typical, and y'all know this, y'all have been asked these questions a million times before, but these patients obviously need to be on a low sodium diet. What food choices would you select that would be low sodium? Clinical symptoms of fluid balance being normal and abnormal. So what would the patient look like that was in a normal fluid balance, and what would they look like if they were not normal? Vital signs post-dialysis and why. Their blood pressure, we talked about, may drop. Their temperature might go up because of the dialysate being warmed. Their heart rate might go up because their blood pressure is down. So kind of knowing some of those symptoms. look up and see what passive transfer is that occurs during dialysis. That will help you understand the dialysis procedure better. Safe care for a patient that's got an AV fistula. You can't be doing blood pressures in those arms that have one. Symptoms, again, if someone's got anticoagulants, what are you going to treat that with? What's the remedy?